¿Estamos? Ok, bien, entonces estamos empezando la última charla del día. We're about to start the last talk of the day, and right now Juliana Codino is joining us from the United States. I will say a few words about Juliana's career. Okay, she holds a PhD, and she's the director of voice pathology at Lakeshore Professional Voice Center and supervisor of the voice-centric clinical fellowship there. Juliana completed her PhD thesis studying the electroglottographic signal and its inflection events. She has a particular interest in acoustics and has been teaching acoustical analysis of voice and phonetics for 11 years. She has written chapters in books and several research articles in scientific journals related to the specialty, and also she has a background in musical theater and enjoys singing for fun. So thank you very much, Juliana, for being with us today, and you can start your talk. Thank you.
Oh, thank you, Marcelo. Thank you, everyone. I'm really humbled to be here with all this brain power in the audience. I had a little bit of imposter syndrome when they called me, but it's a pleasure to be presenting with you at the UNER. My thesis director is from there, so it's really it's a pleasure. So today we're going to talk about challenges in the clinical setting. That is where I come from. I'm coming from the clinical setting. And I want to see if we can figure some things out in voice signal processing. So, well, as you know, a little introduction, Paul Watzlawick, with his theory of human communication, described it, the innate need of humans to communicate. And the voice is the vehicle for this oral communication. And the prevalence of voice disorders varies in different countries, but in the United States, it's estimated to be between 3 and 9% of the population. And this figure increases in professional voice users. The emotional and economic and social consequences impact the person and the system. To make an adequate diagnosis and treatment, it's necessary, in addition to a trained ear, to have tools that will allow to quantify the perceptual analysis carried out by the voice clinician. And voice signal processing is fundamental in the diagnosis and treatment of laryngeal pathology. And if you think about laryngology as a subspecialty, it's relatively new, and it nourishes on these technological advances that you guys have to take care of. Here is just some examples of the things we do every day with our patients and signals that we collect. So let's jump onto why I'm here. I want to see if I can help bridging that gap, trying to extend from the clinical side into the basic science side. So the first thing that I'm going to talk about 3 issues that I found in my setting, seeing patients, everyday voice patients, in a very busy voice center in the outsides of Detroit. We are analyzing small windows of the voice signal in an increased amount of time, and we would like to reverse that. We would like to analyze large windows of the voice signal in a reduced amount of time. So the first signal that I'm going to talk about is the spectrogram that I use every day. I think it's a fast visual way to see what's the spectral components of a voice. And I brought this little sentence from Bacon and Orlikov, which you can all read there, but I'm going to read it out loud too. Every aspect of speech mode or behavior contributes to the final acoustic product, and therefore the spectrogram is likely to tell the clinician more than he or she wants to know about any given utterance. So let's look at a normal narrowband spectrogram. We're only going to talk about narrowband spectrograms today. This is a healthy voice. And the spectrum has been a part of voice and speech analysis for many decades. As you all know, it's a three-dimensional graph that represents time on the horizontal axis, frequency on the vertical axis, and amplitude of the sound components by the color intensity, or the z-axis, or the contrast in the tracing. And the interpretation of a spectrogram is subjective. It relies on a visual analysis performed by the clinician and the association of this analysis with laryngeal imaging, auditory perceptual assessment, et cetera, et cetera. So here we have a nice example of what the spectrogram can show us in the transitions of different laryngeal registers. From glottal fry or mechanism 0 to modal register, head or upper register, into flute or whistle registers. And as you can see in the spectrogram, we can see in those transitions and the different laryngeal mechanics for at least modal and head register. So what do we look for? In 1967, we had this paper from Yanagihara, who classified the spectrographic signal into 4 types. And basically, what he is looking is the relationship between the harmonic structure and the noise component in this signal. It analyzes the regularity of the harmonics, the presence of noise across the spectrum, which can be either interharmonic noise or completely replacing harmonics. And as you can see, this is from the paper. It describes in detail what we should look for in each type of signal. And this is from the paper. Spectrograms today look very different. But one of the things that I struggle with the most, because I have it in my protocol, and when I train my clinical fellows, I tell them you should be able to understand, to read a spectrogram. And if you cannot hear the recording of that voice, be able to tell me at a glance what type of voice I should be expecting. Even telling me if it's more likely to belong to a woman or a man. And sometimes when we're doing this classification, which I use the Yanagihara classification, as I was saying, sometimes it's hard to find that very subtle change between signals 2 and 3. And you may, this may seem like something repetitive with other types of signals, which we're not going to talk about today, but it's one of the things that we struggle as clinicians. This is also from the paper. So we have a very general a guideline from Yanagihara. Plus, at some point, we're only talking about what part of a sustained odd. We record 3 to 5 seconds, or maybe 2 to 5 seconds of an out vowel. It changes across time. So let's look at some examples. These group from Brazil, in an effort to standardize the subjective interpretation of the narrowband spectrograms, they developed a protocol called the spectrographic vocal assessment. They actually do it both for narrow and wideband spectrograms. And they include 6 parameters, including the first one, which we're going to talk about them, the tracing color intensity of the harmonics. So let's listen to this voice. And here's the spectrogram. I used Pratt, MATLAB, and CSL from K-Pentax just to show you how, different tools. I know there's so many out there, but those are the ones that I use regularly. So as you can see, we have, across the frequency range, we have different color intensity for spectrograms. Yes, those harmonics in the formant regions are going to be more, they're going to collect more energy, and they're going to be darker if we have just the grayscale for the spectrogram. And it's not only the variation across time, but also across that frequency range. And here's that other spectrogram with the relationship between harmonics and noise. Another one. And then the last one. Hopefully you heard that. with a completely different tracing color intensity for those harmonics. The next one, if I can transition here, is the presence of interharmonic noise. And as we can see in these other spectrograms, it can be mild, moderate, severe, and it varies across the spectrum. Even if I show you different spectrograms, what should the clinician report in their template for the electronic medical record? What are we going to look at? We're kind of documenting that baseline voice before the intervention that we chose. How or what should we look for across time after treatment? So you can see many of these parameters of the spectrograms are also going to be affected by the dynamic range of choosing. And as I said, the frequency range too. If we think about, I think I have some examples later when we talk about how full is the spectrogram. In male voices with a lower fundamental frequency, depending on if we choose up to 4,000 or 5,000, we may have more high frequency noise than we would if we stopped at 4,000. Then we want to look at the replacement of harmonics by noise. So you can see different examples. How, where, how am I going to pick what I want to report on these very variable spectrograms across frequency and across time? And not to mention that I'm using one only dynamic range. What if I were to change it? Then we also look at the definition and the regularity of the harmonics. So are they defined across time? Do they come and go? Here, for instance, we have a little stop. In voices with unstable or poor laryngeal control, they might be more irregular. And then regarding the filling, as I said, let's see, this one, for instance, this one goes all the way up to 5,000. What if I were to stop up here around 4,000? They would have complete filling of harmonics. But since I had it set in 5,000, I'm going to say, well, it's almost complete or not complete, because I saw that in the last, I don't know, 800 hertz, there was some loss of harmonics. So all that subjectivity is what we don't like, because if the clinician's criteria varies, or there are different clinicians assessing the same patient, we're going to see different things. So we need to find some sort of tool, automated algorithm, something that can pick all these very interesting things that the spectrogram can give us, and see how we can, apply it to characterize this is what the spectrogram, this type of voice is what we're seeing right now. More examples. And then the last one that we look for, according to that protocol, SVAP protocol from Brazil, is the presence of subharmonics. And as you can see, if you look closely here, we can see there are some. I would say they don't have, like, they're very mild in intensity, but they're definitely there, or mild to moderate. This is with CSL. We can see them here. This is a different patient, not the same one. You can see here, we saw this one before, but you can see those subharmonics in between them. And then this one, if I want to look very close, I can see some here. I hope you're all seeing my cursor, because I'm pointing at that. But I can see all those subharmonics. So we need to get this tool that can analyze all those samples, as many seconds as we want, in the 3 dimensions in less time and reduce subjectivity. Oh, one more, many. Okay, so that was the first issue that I wanted to talk about. Onward. Time to diagnosis and the case of the laryngeal dystonias. I'm sure you read about it. Gaston in your group studied this issue. So when we talk about laryngeal dystonias, we have a couple variants. We can talk about abductory or adductory spasmodic dysphonia, essential vocal tremor, or a mixed dystonia where we have both SD with tremor. And then the differential diagnosis is with muscle tension dysphonia, primary muscle tension dysphonia, or functional dysphonias. And finding the right diagnosis will direct the treatment differently. So these are things that we want to reduce the time that the patient has to wait until the accurate diagnosis before we actually decide and land the right treatment. Let's see. So for SD or spasmodic dysphonia, we know they're task specific, they're focal dystonias. It often begins at middle age. And I'm sorry if you all know this, I'm just doing a quick review just to level up and make sure we're all on the same page. It's more common in women than men. And there's usually not an obvious etiology, and it can coexist with other dystonias of their bodies. And 16% of these patients with primary laryngeal dystonias go on to have other areas of their bodies affected. So speaking about their vocal characteristics, with adductor spasmodic dysphonia, we have this involuntary contraction of the vocal fold adductors. We have a strained, strangled quality, hard glottal attacks. And with Botox, we have 90% success rate.
Sunlight strikes the air, prism for a rainbow. The rain.
Oh, hopefully you heard that. And then the other variant is the abductor spasmodic dysphonia. We have involuntary contractions of the vocal fold abductors. We have breathy voice breaks on voiceless and voiced phonemes. And it's harder to treat, but we can also inject Botox into those abductory muscles. Here's an example.
The raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon. There is, according to legend, a boy.
So if we move on to the clinical characteristics, we know that these symptoms worsen on the telephone. Often when they are laughing, singing, or whispering, they don't have these spasms. Emotional situations or stress make it worse. Sometimes they get better with alcohol. We can't recommend that as the therapeutic tool. Patients have a family history for some other dystonia in 12% of the patients. And it was felt to be a disorder of the basal ganglia, but now it feels to be more of a sensory disorder affecting complex neural networks. So, and in the fundamental frequency, it can be very disabling with a severe tremor. The intelligibility is significantly reduced, and they have increased vocal effort. So here's an example.
The rainbow passage. When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is...
Okay, and moving on. So as I said before, these two can coexist, and sometimes we have, if we think about it as a continuum, we can have on one side the pure tremor with regular oscillations. As I said, on the other extreme side, we have the pure dystonia with irregular spasms. Sometimes our patients sit here in the middle, and we need to know which one is the most predominant so we can treat it adequately. We can also think of it as an overlapping of these symptoms and the presentations. So for treatment, as I said, we know that Botox is the most widely used treatment. For adductor SD, we inject the TA muscles or LCA muscle. With abductory SD, we go for the PCA muscles, which is nerve-wracking if you think about it. You're injecting those abductory muscles that create an airway. And then with tremor, typically we inject also the TA muscles, but with tremor, we don't get as much as a decrease in the vocal symptoms, but patients, even though they gain intelligibility, the tremor somehow is always there, but they do report a significant alleviation in that vocal effort that they have to use on an average day. So let's listen to a pre-post adductor ESD.
Sunlight strikes prism.
That's the one you heard before, and now this is post-Botox.
Act like a prism in the form of a rainbow. The rainbow is a division of light, white light, into the many beautiful.
So it's very important that we land the right diagnosis if we can get them as good as that.
The raindrops in the air,
This is
they act like a prism
abductory.
and form a rainbow. The rainbow is a division of white light into.
You heard that one before, and this is post-PCA injection.
When the sunlight strikes the raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white light. When the sunlight strikes the raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white
As
light
you can hear, she still has some
into many beautiful
hesitancy.
colors.
And now let's listen to a tremor pre-TA injection.
The rainbow passage. When the sunlight strikes raindrops,
And post-injection. I should have made this animated. Now I'm realizing. Oh my God.
when the sunlight strikes rainbows in the air, they act as a prism and form a rainbow. The rainbow
ends
is
fairly
a
behind the horizon.
light,
Oh my
There
many
is,
beautiful
according to legend, a
colors.
boiling pot of
Please
gold
take
at one
the
end.
shade of
People
rainbow
look, but no one ever
with its
finds it. When a
path high
man looks for something
above,
beyond
and
his
two
reach,
ends
his
apparently
friends say,
beyond the horizon.
Okay. And now we move
When
to
the sun
no. There. Sorry about that. So what we do tell our patients is that they come to us when they're at their worst. If we have the right diagnosis, they receive Botox. In 2 or 3 days, they become a little breathy. We don't know how long it will take until they get to their best voice as the breathiness fades away. But it varies according to the dose and the severity of the diagnosis. And then once they reach their best voice, again, depending on the presentation and the dose, it will last for a certain amount of time until it starts to deteriorate again. It's a temporary solution. What we see is that if, in that deterioration, if they continue waiting, they go back to their worst voice as they were at the beginning. So we ask our patients to, instead of having a Botox circle, they do a semicircle, and they come to see us the minute they feel that deterioration. So we can re-inject and get them back to, those 2-3 days of breathiness and the best voice and so forth. We ask them to fill out a log. Typically, the top part of our table ranks the breathiness, the bottom, the voice quality. So as the breathiness fades away, week after week, the best voice shows up. And usually that may last 12 to sometimes 16 weeks until they start to deteriorate again and they need Botox. So I'm no expert, and this is a very simplified explanation, but we know that the botulin neurotoxin, the toxin causes a paralytic disorder known as botulism, but in its medical grade, it's purified, the drug, and attenuated. So the local intramuscular injections suppress overactive muscles in these dystonias. And this is the treatment of choice for most focal or segmental dystonias, including blepharospasm, cervical dystonia, oromandibular, laryngeal, limb dystonias, and others. And as I said, 2 or 7 days after the injection, we see those initial symptoms of the toxin, and then the effect can last 3 to 4 months. We have a lot of research on it. We know that it's the treatment of choice. There are some downsides of Botox. They have to get injected in their neck. It's uncomfortable. It's temporary, as I said. They have that initial period of breathy voice. Some patients hate it, and they say, hit me with a very low dose so I don't have a prolonged breathiness and I can go back to work right away, but it will give them a less lasting effect. It's sometimes inconsistent. We can shoot the same patient with the same dose, and sometimes we don't get the same results. And some patients that also receive Botox in other areas of the body, they can develop resistance. I say that because the doses that we use in the larynx are very low. So typically it happens with patients that are receiving it elsewhere. Well, this is how it's injected. Here's the patient, the laryngologist doing a transcutaneous injection. I'm holding the scope so he can see where the needle goes. And this is the thyroid hyoid approach. This is a little video in case you haven't seen one. You can see the needle coming out right there, injecting the left fold. Now he's going to switch to the right side, injecting that TA muscle. Okay, so where's our problem? As I said, the differential diagnosis with primary muscle tension dysphonia, sometimes it's hard, and we lose some precious time that the patient could have already found treatment because we're not sure. Is this adductory spasmodic dysphonia or is this a primary muscle tension dysphonia? So a few months ago, we had this patient coming to our clinic. I'm going to play her recordings. As you can see, she was...
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many.
She was really struggling with a hyperfunctional pattern. We conducted a flex video strobe. Let's see.
A year ago. He eats eggs every Easter. He eats eggs every Easter. How hard did he hit him? Good. Cough for me. Go and go he.
As you heard there, she had some voicing with the cough, right? It's not only glottal fry or that suppressed phonation.
There it is. Sniff 3 times.
At least she can sustain that
like
periodic
eat,
tone.
Eat. Say eat. Podika. Good. Hum. Good. Nice and easy. Good and high pitch. There we go. Good.
I don't know if you can hear her voice
Do it again.
with the strobe light. But anyway, with just minimal stimulation tasks, we could see that she could at least sustain that periodic tone. So this was promising, and we decided to try voice therapy first. And she had 4 or 5 sessions, unfortunately online, so no recordings for that progress. And it really helped her increase the airflow. But after that, the true spasms emerged. So this patient, yes, she would have needed voice therapy regardless, or maybe not. And we could have hit her with Botox from the get-go and attend to her laryngeal dystonia. Would this have been enough to change that compensatory pattern that she was doing? This is just a fun spectrogram of those very hyperfunctional pattern. And then let's listen to this one. This one came to our voice center. Let's see.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
Fortunately, that very same day that she was seen, we had some time to maybe 15 minutes of stimulability tasks with her and trial of voice exercises, and she sounded different right away.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins.
So we decided to just say, okay, let's just try with voice therapy before jumping into Botox, which would be a more invasive option for her. She did very well with voice therapy. Then eventually she came back. The problem with MTD is that sometimes it can creep back in if you're not keeping up with the strategies. But anyway, this was another example. But not all patients respond to therapy so nicely.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long, round arch.
And after a couple sessions, maybe 4 sessions of voice therapy or less, 3 sessions, we were here.
When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is a division of white color into many.
So anyway, she needed Botox, but in the meantime, we had her go through a course of therapy,
When
not
the
knowing. Oh, there. Let's listen to a man for a change. This is before therapy. Oh, I hate this. And this is his rainbow. Or actually, let's listen to the after, I think, 2 sessions.
The rainbow is a division of white light into many beautiful colors.
And then after or mid-therapy.
The rainbow is a division of white light into many beautiful colors. These take the...
So he did well with therapy, continued, finished, and done. But they have these similar presentations that sometimes makes us not offer the right tool from the beginning. So not all patients are so straightforward, and we need to consider all speech tasks too. So listen to this before therapy. This after a couple of sessions, maybe 4 or 5. But if we listen to connected speech.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
And then after.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch with its path high above and its 2 ends apparently beyond the horizon.
So I wanted to present the question or the problem here with you experts. Even though there are many groups around the world that have been studying and are currently studying this issue, there's obviously more than one way to approach it, I'm sure. And I want to direct your attention to what the group, the STEP Lab group in Boston is doing. I heard this presentation at the Fall Voice last month in October. I know the article is not out there yet, but they're using a creak detector for this purpose. It looked promising, but as I said, I'm sure there are more ways to approach it, and there's not going to be only one answer to this problem. And then let's talk about my third question today, which is what matters. And I'm going to move on to singers. We see a lot of singers at Lakeshore. This is a professional jazz R&B singer with voice breaks after she had an upper respiratory infection. She was coughing for a little bit, violently, I think. And if you hear her.
I know about the days to come. Ooh. But we think about them anyway. And I wonder if I'm really with you now, or just chasing after some finer day. Anticipation is...
So as you can hear, she's struggling. She becomes breathy, kind of like, voice breaks in those areas, trying to hit those higher notes. And we scoped her.
Recording.
And we found...
Take a breath. Think E. E.
That left vocal fold is stiffer than the right. They have
Take a
this
breath.
face asymmetry.
E.
She's
Slide out.
hyperfunctional. doesn't have
Keep going.
good laryngeal control.
Good. Take a breath.
So
Good. He, he, he.
my question today is, so what can video stroboscopy show us about that impaired pliability on the left and the use of registers that we can hear it in her singing and the transitions between registers, and what can we estimate from all of the tools that we have in a voice lab, like with high-speed video and all those tools like accelerometers that may take longer, that we don't have access just because they're not practical in a busy voice center. I've been following closely Dr. Sanyartu's work. I think he's presenting later during the workshop, waiting for the clinically accessible version of those models that estimate laryngeal muscle activation, vocal fold contact pressure, aerodynamic information. Because as I said, in a busy clinic, there's no way we can do high-speed video and look 20 minutes of a sustained phonation to give the patient an answer. We have video stroboscopy, we have acoustics, we have aerodynamics, we have perceptual tools. How can we build a map of what might be the best therapeutic option, behavioral, medical, or surgical for a patient like this? Obviously, the map will give us the information. We are the ones in charge of choosing the therapeutic option of choice. If we think about those laryngeal registers, this is obviously a very simplified graph and trying to explain them. From low to high in range, we start with a mechanism 0 or glottal fry with reduced airflow. Then we go to modal or chest register, mechanism 1. That's the speaking voice register, what I'm using right now to talk to you. There's predominantly TA action. And as the pitch goes high, we switch on to the mechanism 2 or the upper or head register, where there's predominantly CT action, which is in charge of stretching those vocal folds for reaching those higher notes. Some people may also go into that mechanism 3 flute whistle register, which is Mariah Carey's signature move. I've tried it in the shower, no success. I can barely match pitch up there. But anyway, let's focus on this circle right here. Between those two, we have that mixed register that it's used a lot in professional, or not professional, in singers, musical theater singers in particular use it a lot. But what most Western musical or performers want is to have a smooth transition between mechanism 1 and mechanism 2 with no breaks. And that transition area between both registers is called the passaggio, as you probably know already. And it's the most sensitive area for vibratory impairment. If that transition does not happen smoothly, then we have a break. And here's an example here of a nice break. So the singer shall remain nameless, but those are one of the things that sometimes patients come to see us for, like, oh, I have a break in the passaggio that I didn't have before. And we scope them, we see something, and we say, oh, this is not a normal looking larynx, but do we know if that is what is causing their problem? Do we need to intervene into whatever we see that is now not looking quote unquote normal or not? We saw this before. So these are those, passaggio areas. I just put it there again so we could see them. So if we think about the different layers of the vocal folds, when I was talking about that very sensitive area for vibratory impairment, the passaggio, if there's anything impairing that mucosal wave in the superficial lamina propria, the layer beneath the epithelium, or if it's loss, if we have some superficial lamina propria loss, then hoarseness or some sort of vocal symptom will occur. Or a mass may impair the mucosal wave too. So another example, here's a professional singer. She came to us with complaints of vocal fatigue. She had increased voice demands in the last year with a new teaching job. Here's her singing voice.
I forgot the words.
And when we scope her,
Recording.
we see that little, very flat, mass-looking irregularity on the left vocal fold with some contact indentation on the right. How do we know if this is what's causing her symptoms? Do we need to take her to the OR? Do we need to do voice therapy? So we want to integrate all the information that all of our tools give us in a busy voice setting to see how can we give the best option to our patients. So wrapping up, whenever we talk about, when I say we, is Dr. Rubin and I, the laryngologist that I work with at Lakeshore, we talk to about the care of the performing voice, professional voice in general. And we say the voice team, we have the patient in the center, the voice pathologist, the laryngologist, the singing teacher, the director, vocal coach, musical director, whoever plays that role over here. But today, I wanted to add you guys here. You all this, and I'm sorry if I missed some subtype of engineer here, but you are the ones keeping our backs. You're the ones that are holding us there and giving us all these tools that we need. So collaborate, reach out. I'm happy to discuss any of the things that I talked about today and transform them into a project. And that's about it. Let's bridge that gap. This is very Michigan looking at this time of the year. Let's see, where are you? Here. I can't hear you, Marcelo.
Thank you very much, Juliana, for your great talk. And I think that for the sake of continuity, we can ask the questions in English. Is that okay?
Yeah.
Okay.
As long as I can understand them.
Yes. So questions? Don't be shy.
Hello.
Oh, it's him.
Yeah, I had to come first because you mentioned my name. So that was a great talk. Thanks, Juliana.
Oh.
I was going to ask you about your experience in the clinical domain with ambulatory voice monitoring. We've been working on that topic for some time, and I was wondering if you see that becoming truly the promise that it was meant to be. If you can comment on that, and then I'll ask you something else.
Okay. Well, unfortunately, I don't have experience with that. I did meet with a group in Texas. They wanted to do a project following phonotraumatic lesions post-surgery with those monitors. We were happy to say, yes, let's do it. But when we see how much, at least at the time, this was a couple of years ago, pre-COVID, it involved so much time from the patient in certain things. And we need to find the right, population that wants to jump onto that. I'm sure things have changed since then, because 3 years in this realm is probably a lot. So I'm not up to the latest. But how easy, why don't you tell me, how easy would it be to tell one of our patients to say, okay, you're taking this home, you're taking care of it, you're wearing it every day, your privacy is, I know all those things are taken care of, but how do we sell it?
So what we typically say is that you will be able to get additional information in terms of voice usage, right? So things that you wouldn't see in a rainbow passage analysis. So you'll get a better feeling of what the person is doing. And that seems to be quite important when you're looking at certain voice problems, particularly hyperfunction, which is the case that we've studied the most. So that's why we typically think, right? But I was wondering if you see that in the clinic as being the potential that it is meant to be.
I think that all the information that we can obtain from those ambulatory devices is great. You don't have to sell it to me. My question was, how do we tell a patient this nuisance that I'm giving you? I mean, I know that, for instance, at the MGH group, they do have a lot of work on that, and they actually pay their subjects to be part of the project. This is someone who works as a teacher, has voice complaints. They come to see us, you know, at some point in their life. We find something, we treat it, and it's even harder to get them to, you know, complete the follow-ups. So that's the little link that I'm missing with ambulatory voice monitoring. How do we sell it to the regular patient that is not a subject in a NIH grant, that is not getting paid for it? And again, that's what I'm saying. I have not participated in a project where I see how much of a nuisance that is. Maybe it's not as much as I think. And we could sell it better.
Right. It's a good point. I think it's still in the research process, and there are so many research problems, technical problems that need to be faced. Because and I'll be talking about this tomorrow. So we record hours and hours and hours. So this is an 8-hour a day for 3 weeks. And this is high bandwidth recordings of accelerometer data, and sometimes accelerometer and something related to, you know, voicing or like a microphone that it's being pre-processed. But in terms of the data analysis, there's the challenge of what do you do with this data exactly? What specific topic are you be looking into? So I think we are still in that stage. And most of us working on this are not clinicians, so that's kind of a gap. But we still have people who are in the clinical side. But I was wondering how you see it. And then the other question I had for you was on quantifying. You mentioned that you would love to see some of the efforts, and you pointed to the work that Kara Stepp had done. And there's an engineer here, the second author, Manuel Diaz Cádiz, which was former student in our group, and I can see how engineers can really do what you're saying, which I think it was automatic tremor detection for that.
Yeah.
Yeah. So
for them was for sleep. Yeah.
So you think having these automatic tools is what is needed the most at this point for the current stuff you currently do? Because like in contrast to ambulatory monitoring, which is very new, and I don't even know how to analyze the data. We're still looking how to do that. But this other tools that you were pointing, the other analysis are clearly feasible and very specific to you. So would you say that what we need at this point is more of that type of work?
Yes, I think that it's not all of it, but yes, we do want. If you think about the time between onset of symptoms until they get a diagnosis for spasmodic dysphonias or laryngeal dystonias, I think it's 4 to 6 years. Patients move around. General ENTs, they go see their allergist. They see, if they're lucky, a neurologist, and if they're very lucky, they land at a voice center where we do all this, and the time that they lost is only maybe 4 sessions of voice therapy, which is not ideal, but it's not 4 to 6 years, right? So if we had, automated ways to tell a general speech language pathologist or a general ENT who happens to see a voice patient in the middle of Idaho where there's no access to another specialized voice center, if they can use whatever tool we give them to say, hey, if this falls beneath this threshold, this is the way to go. If this falls above this threshold, this is the way to go. Something that would simplify that detective work that sometimes we do. And we have all the tools to do it right, we think. At least we like to think that we have all the tools at a voice center to give them the fastest solution to their problem. And sometimes that's not the case.
Right, thanks. It was great seeing you. Nice talk.
Same here. Thank you.
Okay, more questions? Okay.
Hi, Juliana. Nice to
Hi,
meet you.
Gaston.
My question is about, do you know the prevalence of MTD and SD? Or if one of these is much more common than the other?
I don't know the prevalence, but I do know that at a voice center, I would say, you know, we probably see, well, we do have a Botox day where we see from 4 to 9 patients that receive Botox periodically every week for any type of laryngeal dystonia. And for primary MTD, at least in a month, I would say we diagnose in where we are, maybe 3 a month for sure, or 2 a month. I don't know if that gives you an estimation of what you wanted.
Yes, yes. And the Botox treatment is available in Argentina or in South America, or yes?
Yes, yes. It is expensive. Insurances don't like to pay for it. I'm a little bit out of the sphere of, you know, how medical coverage goes in Argentina, but it was covered when I left. You just have to have the diagnosis.
Okay. Thank you, Juliana.
You're welcome.
Okay. Yes. One more question from Gabriel.
All my favorite people.
Hi again, Juliana. Thank you very much for this talk. And again, thank you very much for all these very enlightened examples. They are great and help us to understand the issues and the problems that you face every day in the practice. Talking about this automatic system that you are interested in, as you know, the best that this kind of system can do is to try to mimic or imitate what we teach them to do. And for that reason, we need some samples. So questions are related to that information. In your opinion or your knowledge, there are any database or set of images that the clinicians and all the people working in voice therapy agreed in what they see or what that information represents in order to then use it to train in different automatic systems?
Are you talking about spectrograms or,
yes, about spectrograms.
Or in general?
About
well, I did. Yeah, I did show you the lack of. There's that paper from '67. Then there's a big gap, even though spectrograms are out there and we use them. There's not like a nice protocol. I mean, protocols, there are many. You can say what you want to look at, what you want to grade and value, but there's so many variables and dimensions within the spectrogram that it's hard. And I deal with this every single day. I see a patient, you know, some days I do above 18 or new recordings for patients that come to the clinic or they're following up treatment. And I do, you know, a visual analysis of a narrowband spectrogram. First of all, which part am I going to pick? Even though I tell the patients hold it for 4 to 5 seconds, I usually pick the central 2 or wherever I feel like it's more representative of the patient's dysphonia, how do we even pick that? And why am I omitting all that other, seconds at the beginning or at the end that may give me also some interesting information? So first of all, that's the first issue. And then even though we have that, SVAP protocol published a couple of years ago, going item by item, they used a visual analog scale for each item, and then they said if it was in the low, mid, or high regions of the spectrum, and if it was mild, moderate, or severe, for instance, the presence of interharmonic noise. I mean, we have the protocol, but it's subjective, and I see it whenever I have a new clinical fellow and I'm training them, or a student, and I'm telling that, this is a spectrogram, this is what we do, this is what we look for. And it shouldn't. I mean, the information's there. It's a voice signal. Obviously, we would have to have standardized parameters. That's the other question of the dynamic range, as I said, or the frequency range. But once we kind of like work around that, shouldn't we be able to come up with a number, a compound of some sort, knowing and maybe even weighing what is more important? So I kind of like trailed off from your question. The answer is no, we don't have a standardized tool. Everyone looks at spectrograms. Everyone knows what to look for in a spectrogram, but we don't have it. So that's where you come
sorry,
in.
can you repeat that? Because we have a break. Can you repeat the last part?
Oh, yeah, I said everybody knows, every clinician knows what a spectrogram is. They might use it more or less in different voice centers, for preference reasons, but we don't have a standardized way to report what we see.
Okay, another question. For example, you give us this idea of using in a scale, in a continuum. I remember a previous software from K-Pentax that show some visual images that rate different numbers, different scales. And in your opinion, which of these tools would be more useful, more interesting in the practice? Have only 2, 3 numbers, or have this constellation of variables, and how how to compare different cases in this kind of spider representation, web representation?
That's a great question. I'm guessing you're talking about the MDVP that kind of like shows the central normal and how each parameter.
Yes.
Yeah. So that one was a nice way to represent those parameters. The problem is that they're not robust. And if we think about a compound number, like for instance the CPP, which would be a more robust measure, and we use that CPP that was low and falling below what we would expect as the patient gets better, goes back, falls into whatever new norms the voice center is using. I think the last paper with norms was in 2021 from the MGH group. And then as the patient gets a little more hyperfunctional, it starts going too high. and it's still within the normal range, but we hear a pressed voice. It's not as noisy. So the question is, would a compound help? Would I love to have a number for the spectrogram weighing every single thing that we look at? Yes, it would be lovely. Would it be perfect? I don't know. Would a visual representation like the MDVP thing that you were talking about help? Yes, certainly, particularly for clinicians that are not necessarily very experienced in spectrograms, it would certainly help. But as with any calculations, we also have to have the, our interpretation say, oh, this one, I don't know. I'm just thinking, if we think about the MDVP, how sometimes I don't really care for this patient with atrophy if this one is within abnormal limits, because that's not their main concern. So it would have some subjectivity to it, but at least we would have the results from the evaluation taking into account everything that we look at. So I think both would be good tools, and maybe it can be a combination of both.
Okay, thank you very much.
Oh, thank you. Great question.
Any other question? Okay, I think I have one myself.
Yeah.
Okay, so you showed us some spectrograms, and you said they were narrow band spectrograms. Okay.
Yes.
So I'm guessing that you want a narrow band spectrum so you can all the harmonics more or less well defined. But do you use the same bandwidth for all the patients, or is somehow the bandwidth dependent on the patient? And also if you use the same for men and women?
So in the examples, you caught me, because the examples that were done on Pratt, I had a different bandwidth today because I took them from an old presentation that it was done by, with certain parameters. Now what I did is I worked with an engineer at K-Pentax, and I said, just build a macro for me. I want this bandwidth, this dynamic range, this frequency range, and this filters. So I can all see I can see all my spectrograms with the same lens. But for instance, if I have a vocal fold paralysis who can barely touch, or maybe they don't have any contact, I'm recording I might sometimes tweak with the dynamic range to see a little bit more, because if not, I would see a white, or maybe even very, very, very light gray scattered noise. And if I want to see if there's some trend somewhere, what am I going to look for when they get the injection laryngoplasty, for instance? I might tweak the dynamic range a little bit, but then all the other parameters are stable.
Okay. No, because I think that adapting the bandwidth to the patient, or at least to the fundamental frequency of the patient, would help in differentiating these different harmonics, which is, I think it is what you want in the end.
Yes, to do it patient-centered.
Yeah, because, I mean, there are also some tools, post-processing tools, that would help you to improve the concentration on the spectrogram that might be useful. I mean, okay, you choose your bandwidth in order to have a good separation between the harmonics, but also there are some post-processing tools that might help you to have a more defined spectrum. Maybe that can be useful for your purposes.
Yeah, and it's funny that you said that, because Pasquale Botalico from University of Illinois, we collaborate with other projects, and one day we were talking about this, and he mentioned exactly that as another option. So yeah, now there's two people telling me the same thing, so probably we're onto something.
Okay. Thank you very much, Juliana. I don't know if we have any other question. No? Okay, so thank you very much.
Thank you. Bye.
Okay, so we will continue tomorrow at 11 a.m. Mañana a las 11 de la mañana empieza el segundo día del workshop. Gracias.